title today was best tapering regimens, which I am going to do my best to go over. I think the summary outcome of this would be there is no one way to do this and there is no best answer. But hopefully there's some guiding principles and things that may be helpful. And this is a very med heavy lecture, but I always really do support those of you who aren't prescribing medications, how important it is, especially if you hear from families or hear about some of these symptoms in therapy sessions. It can also be incredibly helpful to be aware of and communicate. Why do we talk about tapering medicines? Well, there can be a lot of different reasons. For some illnesses, if you suddenly stop a medication, especially for a chronic condition, you can certainly have a higher risk of relapse if the medicine isn't tapered. And we certainly know that patients with bipolar disorder, thought disorders, major depressive disorders, the longer time they have of recovery and stability on the medicine increases their likelihood of longer improvement if they stay on their medicine. Suddenly stopping it could trigger a relapse of the condition. So certainly a slower taper may catch the reemergence of symptoms rather than a sudden one. Many of these medicines, especially if people have been on them for a while, can have a withdrawal profile, sort of physiologic, sort of an array of symptoms that can be uncomfortable if a medicine stopped too suddenly, and we'll spend a lot of time talking about that today. Sometimes we're trying to increase tolerability as we increase the dose. And this part is a little bit, I think there's a lot more evidence base when you're tapering up. Because often there's more data on what efficacious doses are to treatment. So you can kind of have if you know what the diagnosis is and how you're using the medicine, there's more to guide you on how to get to the target dose. And for some medicines, especially SSRIs and antipsychotics, some people may not be able to tolerate the full target dose that you're trying to get to for symptom resolution without slower adjustments. And so you may be going slower to increase tolerability. And then sometimes you have to taper medicines because the medicine they're on isn't working, or it has no efficacy, or it had efficacy and it lost efficacy, sort of a fancy term called tachyphylaxis, or sort of related to receptor modulation when the receptors or sort of pathways aren't kind of as responsive, or the very fancy term, the medicine just seems to poop out that we see after a while. And sometimes that's an indication to try to get them on something that is more helpful. So as I said before, there is a lot we don't know about this. And as I was, and I think I've done it differently so many times in my self-practice that I was not totally shocked that when I went into the literature, I had a lot more time finding really good guidance about this. In fact, it's been a little bit more kind of recently, there's been a little bit more efforts on this, but I think the take-home point is that there's no one way to do this. It really is close monitoring, good communication, listening to your patient, and doing what's best for them based on what you're seeing. So a couple things to always just, again, remember when you think about this is, you know, for patients coming off, staying on, switching, it's always that conversation. What are the risks and benefits of the change? Staying versus changing, and which one kind of outweighs the situation, whether it's side effects or the illness itself. And one of the lessons that was really important that I learned as I started writing medicines all the way back in training is there really is a risk of not treating things. And it's really important to think about what is the risk of not doing anything, because sometimes that risk is substantial. And so when you're making decisions sometimes about suicidality or psychosis or ADHD or even like issues like pregnancy, what's the risk of not treating it versus actually treating it can be a really important decision. And sometimes it's a decision that the patient may have strong feelings about. And we need to have good communication about that. Other factors are how long have the symptoms been in remission? If someone has had an episode of depression and been in remission for 6 years, that's a really different patient that you might be tapering off of or making recommendations for versus one that's still having pretty profound symptoms. So how long they're in remission or the symptom burden could be a factor. There may be other factors that increase success or chances for coming off. You know, if a patient maybe with anxiety has had a really substantial therapy experience, learned a lot of coping skills, a lot of the previous stressors are now stable, they may have a lot of success coming off medications than they might not have if they weren't so far removed from it. Some patients are having side effects. Some patients just don't like the idea of medicine. All of those can play a role. Sometimes it's important to think about what are their mortality risks related to their illness. A patient that has had frequent severe suicide attempts during depression may have a different risk of coming off medications than one that did not. How functionally impaired were they? You know, if they had bipolar disorder and every time they stopped their medicine, they ended up in the hospital because they couldn't sleep, is a different patient than one that just had mild symptoms. And so you have to take account all those things. It's also important to think about when should we make a change. Times of stress and pandemics and change are not always the best time to make medication changes. I work with a lot of kids and it's usually not a great idea to change when there's lots of other things changing, especially if you're making decisions to come off things. And so when things are consistent as much as they possibly can, that makes the most sense. So you're not having stressors from other things causing changes. And then you may be making a decision about coming off medicines or if we need to replace it with something else. That could all be a factor. So again, this is sort of that risk of relapse point. And these are always sort of facts that I think are helpful to kind of discuss with people, but also take into consideration sort of personal choice. If you've had one lifetime episode of depression, you have about a 50% chance of having another in your lifetime. So that's 50-50 odds. And for a lot of people, that means that if you've had one episode of major depression and you've been in remission for about a year, you may be able to successfully come off those medicines with self-monitoring. However, if you've had multiple episodes, that risk of recurrence goes up substantially to 3 episodes of major depression almost has a lifetime risk of another one, almost 95%, which is pretty significant. And so a lot of times with recurrent episodes, you're discussing the idea of maybe we should find something that you can stay on long-term to really be more preventative in that regard. Anxiety disorders can also have, they're a little bit less predictable, but they do also have very high rates of recurrence. Especially during times of stress or big trigger changes. And they may be able to come back. Now, anxiety disorders can often, with really good psychotherapy, often be managed. And some patients will be able to work through those with really good therapy experiences. But sometimes the recovery time to stay on medicines is a bit longer than depression. Sometimes they recommend a year to 18 months as well. And then certainly psychotic disorders have a very high rate of relapse. You've had one psychotic disorder in your life, you have almost a 95% chance of another psychotic episode at some point. So really having that information can be helpful. And it's not to say that it means that you always have to, but you have to look at factors like how good are they at self-monitoring? Can they catch the early onset of the symptoms returning? Do they have family support that might help them catch it if it recurs? The reality of our profession is that it is a disorder of the brain. And sometimes when people are sick, they lose insight into their own symptoms and need help from others to sometimes point them out. And some disorders have very high rates of mortality. There are really pretty high rates of early death reported in patients with thought disorders, and that stopping antipsychotics really increases the risk of death. Some of that's related to paranoia and risk-taking behaviors. And then there have been reports that people that discontinue lithium with profound mood symptoms might have higher rates of suicide once that lithium is stopped. So you have to balance all of those things. And sometimes it's hard to tell the difference between the medicine like wearing off, like is there withdrawal symptoms from the medicine, or is this like a relapse of the illness? The key with that is usually that it's timing. When you see symptomatology emerging shortly after the change, within days to weeks, it's probably some withdrawal profile. Usually illness relapse is something that may come within months or sometimes years. It's usually not as immediate. There's usually a bit of a delay. So different medications that we use can have different withdrawal profiles. And a lot of this depends on, and our pharmacists can help us out with this today, but a lot of the medicine pharmacokinetics and pharmacodynamics may play a role in what we see regarding different withdrawal profiles. The intensity of the medicine binding to the receptors, binding affinity, and dissociation rates from the receptors can kind of determine whether or not you can have physiological withdrawal. The half-life of a medication might determine how quickly symptoms occur or progress. What target receptors and neurotransmitters may have been occurring can affect that. How long the medication has been prescribed. Generally speaking, the longer a medicine is on board, probably the more likely that withdrawal could occur. Some medicines have a clear physiological dependence. Some are more psychological in their dependence. Some medications inhibit their own metabolism, and so they speed up the way they process themselves with time, and that can affect and make it harder to come off. And you can get kind of paradoxical effects and hyperreactivity for some people. There's a phenomenon called neurological kindling. That's sort of a theory of sort of, if you've been exposed to it before and had a reaction, does it sort of trigger the kindling effect and make it happen faster? Sort of allergy theory a little bit, but a little bit more complicated than that. And then the higher the dose of medication might affect how slow or fast you can go as well. So we're going to kind of do the rest of these by class. I think antidepressants are probably the class of medications gotten the most attention. And I think what I would say clinically is, I think the reason for this is it is so variable what you might see. There are some people that just stop them and never feel a thing, and can just stop them and go. And there are some people that you just find with this kind of slow, gradual taper over weeks. And then there are some people that are so sensitive to this that they've sort of, and we'll talk about it, have talked about microdosing strategies to really help prevent them. And so this can be a very variable pattern for different people. And more data is coming out about folks that are really having those protracted withdrawals and how they come off of it in the literature lately. So the most common ones, of course, are SSRIs. I would say that some of the SNRIs will also have similar patterns like this, and tricyclics as well, due to some similarities. But this is sort of the vast array of strange symptoms that can be associated with SSRI discontinuation. And you can see with some of the really sensory ones and general ones, they're just vague, weird feelings that you get in your body, and they can sometimes be confusing because lots of times when you're depressed or anxious, which is what these medicines are for, is you can also have kind of bizarre physical odd symptoms that are going with mood and anxiety. And so it's really hard and important that we don't minimize the side effect withdrawal someone might be having, as mixing it up with the mood symptoms, because it really could be withdrawal. And a lot of times it's that timing factor again. How quickly did they emerge after you attempted to change the dose? So the sensory symptoms are really strange. They're like numbness and tingling sensations, shock-like sensations. People have weird visual sound things that are just odd. They usually know they're not real. They're not like psychotic things, but they're just strange. These are very similar to some of the things people are reporting with COVID. And there's odd neurological weirdness. A lot of people complain of kind of fatigue and flu-like symptoms with sort of tremor and slight changes in their heart or appetite. They can have some mood changes, just feeling a little more moody, irritable, tired. Some people get more autonomic sort of things like dizziness or lightheadedness or a little bit of gait instability. You see changes in your sleep and in your dreams because SSRIs do sort of inhibit deep sleep. And so there's some, especially with long-term use, some dysregulation of sleep architecture that might occur that kind of rebounds back when it's tapered. You can have GI symptoms as you get the dose up and when you get the dose off. Sexual side effects are actually pretty marked and a common side effect of SSRIs. And so as the medicine comes off, you can get some strange symptoms that way as well. And then anytime you're sort of making issues, some people kind of complain of some changes to their focus or concentration or memory and kind of vague confusion-like symptoms that can occur. And so this is a very strange, non-specific weirdness. And I liked this mnemonic, the Finnish mnemonic, like some of the most common ones that people might have as you try to change these. So flu-like, sleep changes, the nausea, imbalance, sensory, and hyperarousal symptoms to kind of help you remember. And also really, really talk to patients about. So that one, they're not terrified about it. Sometimes the anxiety of not knowing what it is can be more disturbing than what they're actually experiencing if it's not. And I always sort of ask people when we're tapering up or tapering off, I go, well, you're gonna probably feel something, and these are all the weird things that can happen. What I'd like you to really think about for me is this a mild annoying thing that you just realize is there? Is this moderately bothering you, or is this really severe? Like, I can't take this. We need to do something to really kind of gauge the severity of it. Because if it's mild and moderate, it's probably going to resolve itself if it's not intolerable, just with a little bit of time. If it's severe and the withdrawal is worse, we're probably going to need to make some changes. So here are some of the strategies that have been discussed. And as I said, this is very person dependent. You don't usually see doctors telling people just stop it. So that's usually one that happens on people's own, but a lot of people will stop it. Honestly, the most common thing is I have people that can't get to the pharmacy to pick it up, and they ran out and they feel like crap, and they don't really know why, because they didn't have a refill or something happened with an authorization. So that's probably the most common reason people sort of cold turkey stop it. Some people will do just fine kind of with a rapid taper, and maybe over a month you cut it down by about 25% a week. Some people will tolerate that. I tend to usually start people, especially if I don't know how they're going to react, kind of more with the next step, where I try to taper it off over about 6 to 8 weeks, kind of with a dose drop every 2 to 4 weeks if we can. And I kind of give people a little bit of control with it. Like, let's plan to do this. If you're not noticing anything, you can go a little faster. If you're starting to have some side effects, don't go any further. Just sort of pause, let it settle, and then sort of resume. And so this newer sort of strategy of a 10% dose reduction every 2 to 4 weeks is kind of the more slower version that has come out, especially for people that might be more sensitive to this. And then we'll talk about some other strategies, but there's a group of people, and they're very active online. I came across all these websites about people that had even problems with this 10% reduction, and what we can talk about some of those strategies. And again, you're really balancing that discussion between what's a side effect and what's truly the reemergence of the illness. And again, timing is important, but helping people kind of remember which was which can also be helpful. So whenever I'm tapering something off, I kind of go through with why we started it in the first place. We started this when you couldn't get out of bed, or you had those really negative thoughts and you had no energy and you were having trouble focusing at work, and kind of go through what was there before, so that we can be the self-monitoring. But then also talk about, as we lower the medicine, these can cause some maybe weird feelings in your body. Kind of talk about that Finnish mnemonic a little bit, and kind of talk about that monitoring of both. Antipsychotics also have kind of their own withdrawal profiles. So these are patients usually with bipolar disorder or psychotic disorders that may have complicated withdrawals. And the thing about antipsychotics, as our pharmacy friends will tell us, these are like the dirtiest drugs on the planet. They hit so many different receptors in our bodies, in our brain, that there's tons of side effects that can occur both with the taper up and the taper off, as various antipsychotics hit different things. And there's beautiful little charts that tell you which one are stronger at different receptors. But most antipsychotics are not very clean medications. We talk about serotonin and dopamine often as the efficacy agents of the antipsychotics, but they tend to hit all the other receptors as well. So you really, this is like the overwhelming table of everything. Because really most antipsychotics, depending on their profile, can have very different things. Some of the more interesting things that I think are worth pointing out, and you'll see all of the same serotonin ones here, but you do also have a lot of autonomic symptoms. And so autonomic can be both the activation of our parasympathetic or a sympathetic system. So those are the systems that rev you up and like the adrenaline surge. And those are the resting symptoms that help you relax and rest. So when you're messing with those symptoms, you can get all sorts of things like dizziness, lightheadedness. You can get tachycardia. You can get palpitations. You can get this whole array of effects. And you can have impacts on your sedation from histamine and cholinergic symptoms and just everything. One of the really interesting things that often happens, and this is I've seen this a lot. This usually happens in my patients that can't get their antipsychotics. When you suddenly stop a dopaminergic drug, you can get this weird, bizarre increase in movements. They look like tics. It almost looks like a tardive dyskinetic movement, but it's occurring when the medicine's really stopped. And this is a really terrifying thing for families to say, I can't get their medicine, and they're like making weird postures and their arms are jerking. And that's actually the rapid removal of the dopaminergic blockade that can be really kind of disturbing to kind of see. It usually corrects, but it can be really a strange one that people can report. And certainly having some of the changes rapidly with like alertness can be kind of strange, but you can really get about anything with these antipsychotics. The other one I was going to really highlight was benzodiazepines. Psychiatrists don't much like being on benzodiazepines long term. There's not great evidence that long-term use over a month really is as helpful as some of the newer ones, but one of the biggest challenges after a month, there actually is a physiological dependence that can occur with these medicines. And much like alcohol, there is a risk of death if these medicines are stopped. So after about a month, most people will have some degree of physiological tolerance. And many people have been on these medicines for decades. And they're very hard and they're very uncomfortable. And there's also this huge psychological fear of coming off them too, often because they were used for anxiety, and people are really worried that they're going to have horrible panic attacks or anxiety as you come off. So you end up having this dual mental fear as well as true physiological fear that can be there. And so this kind of depends on how long you've been on the medicine. There's differences in benzodiazepines, whether they're short acting or long acting. It actually turns out that the short acting ones like Xanax are really hard to take people off of because what ends up happening is they often are in withdrawal at the end of the physiological dose before the next dose, and they're taking them 3 or 4 times a day. And there's almost like this rebound, anxiety, withdrawal, panic that kind of occurs. And so there's a lot of cognitive worry that comes with that feeling too. And so Sometimes decisions are made about switching to long actings to make that smoother. But usually with the long actings, they don't feel them act as fast as the short actings do. And so there's gonna be a lot of factors in this. And so, you know, it's also really hard to convince someone to come off of their benzo that they've been on a long time, because as I said, they're thinking about their life before it was started if they had benefit. And so sometimes when it's urgent, sometimes inpatient admissions are warranted for benzodiazepine withdrawal, especially if they have a history of seizures or other withdrawal signs with vital sign instability. That might be a reason for a psychiatric admission. And that's because we can monitor the vital signs and give rescue doses as needed. But as an outpatient, usually what you end up doing is you can get the first half off pretty quickly. It's the final half of the dose that sometimes requires a smaller deduction every 1 to 2 months. And, you know, when should you really think about a benzodiazepine taper? Is really, you know, in elderly patients, these medicines can be particularly problematic because you really do have some cognitive dulling that occurs in how they process information. It can increase the risk of falls. So there's been a lot of movement to try to really avoid these in patients over 65. The other really big area is the benzodiazepines combined with opiates have shown to have a significant higher risk of mortality and been a really big cause of death in people mixing them. And so it is one of the things that even in substance abuse treatment, they usually highly monitor if people are taking benzos with things like Suboxone, because it really, those two medicines together can have a synergistic effect and suppress our breathing drive. So people stop breathing when those medicines are in combination. And so often those have to be tapered because of that. Again, because it's sort of impacting how we consolidate memory and thinking. We often think about stopping it in patients that might be developing dementia or cognitive disorders, have a history of traumatic brain injuries. Benzodiazepines can also be disinhibiting in young people and older people where they get a paradoxical agitation response that can occur. And then certainly benzodiazepines combined with alcohol or other sedatives can also have a higher risk of death because of that synergistic effect on breathing. And so again, this is the one that really can be life-threatening if stopped urgently. And so this is a super big challenge in the outpatient world when you have trouble getting patients in for their outpatient appointments. They're missing appointments, but they're calling wanting a refill, and you want to see them and you want to lower it, but you can't get them in and they don't want to lower it. And it's a really hard thing because if you did stop it, they would really be at risk. And so it's a challenging one if good monitoring doesn't happen. And again, as I said, that first half is a lot easier to get off than the lower half. And so usually try to go a little faster at the beginning, but expect that over the last half of the dose range, it may take several months to lower. And so a lot of people talk about doing like a 3 to 6 month taper very slowly of these medicines with good communication. However, trying to extend the taper beyond 6 months, interestingly, causes so much anxiety that too long of taper can also be problematic. And so it's really, again, a lot of balancing. So how you can kind of think about benzo tapers, there's a couple of different ways you can approach that. One strategy is to use the medicine they're taking and start just sort of slowly cutting the pill or cutting the dose over that time. We talked about the switch to a longer acting medicine. So instead of going from something that someone was taking 4 times a day, you might switch it to something that was twice a day. And I think psychologically, sometimes that's actually a little bit more helpful because they don't quite sometimes have the association with the dose and the response. So it's a little, it kind of can help with that piece a little bit. And then you can also use medicines that help manage the physiological withdrawal symptoms. And so benzodiazepines predominantly increase the flow of GABA, which is an inhibitory neurotransmitter, so that it's kind of a calming agent. And so all of these adjunctive medications also kind of help block either the excitatory or increased GABAergic potential to decrease the risk of seizures, but also that increase in some of the GABA receptor can actually help lessen the physical withdrawal symptoms that people might have. And most of the physical withdrawal symptoms are things like agitation, vital sign instability, shakes, tremors, gait instability. And then in the far ends of it, people can almost have like a delirium tremens picture. They could hallucinate or seize. So it's a lot of physiological arousal response that can happen. It can be very psychologically and physiologically uncomfortable. So again, there's still a lot to learn, and I think we need much more research. I suspect that some of the differences we're seeing in withdrawals are also related to how people have differences in metabolism and CYP receptors, and probably there may be more individualized approach coming, but there are different strategies. As I said, the old approach was this larger half than half sort of approach. We're kind of doing more of a 10% rejection every 2 weeks now with some of these things. And for those, especially with the SSRIs, these are what some of the advocacy groups have gotten to, that some people are so severe in their withdrawal symptoms that they're talking about a 10% reduction per month over like years for some of these doses. And there are even forums online that talk about crushing your pills or opening the capsules and doing one little bead one day and one the next, and using jewelry scales to try to lower it, because people are really reporting such a severe withdrawal effects that it can be kind of interesting to read, but it helps. It does seem to help, and I think it gives them some control to be part of the process a little bit too. And so at the end of the day, the unknown and the individuality is really key, and just really having that comfort level with the clinician to talk about it, to educate them about what to expect. You know, I really do find it helpful to give kind of people that control. Like, if it's mild or moderate, you think you can tolerate it, stick with it. Just don't go any faster, or give him that trouble. If it's really bad, bump it back up to where we are. Just because I think the worst part is it always happens in the middle of the night when you can't call your doctor and you have to wait 2 days for them to call you back. And so really having some understanding of what you can do in the moment can really be helpful. And as I said, the timing really, really matters. So just some basic things. Never stop your medicine abruptly if you don't have to. That's a really good way to make the worst of it. Really talk about it and be open to talking about and having a plan with some guidance if you have symptoms or a relapse. You know, sometimes I tell people, you know, especially like with antidepressants, I said, you know, keep the bottle. If your symptoms start really coming back and it's been like 2 weeks and your depression comes back, let's start it back. You can start it back and call me on Monday if you have to start it on the weekend, so you can kind of plan ahead. Don't expect it to be quick. Be reasonable. It's going to be faster for some people than others. Talk about self-monitoring and realize that stopping is not the only option. Sometimes if they're really complaining about a side effect or some of this up receptor regulation, there's lots of times you can fix it or get a different response by trying a different medicine in a different class. And so there are always options. And just really communicate and have a good communication plan to do that. Tapering up medications is generally a little bit easier. Again, the rules aren't much different. They're the same as far as tolerability, but we kind of usually have more of a target dose that we're working at, because we're really kind of trying to get remission of some symptoms. So I think it's a little bit more clear. One of the things that I wanted to comment on, and I think this is an area of great misunderstanding, but a lot of times the tolerability issues in increasing the dose are often related to metabolic issues or genetic issues. And there is some companies, and this is the one I'm most familiar with. I have no financial obligations or commitments to them, but this is the one that we tend to use. And it is it is a luxury test that is clearly trying to make money and a niche for itself, but it really does have some benefits. So this particular company, GeneSight, it's a cheek swab. You can swab someone's cheek and mail the DNA into the company, and they create this beautiful report with fancy colors and lots of charts. But really what it does is it looks at how you as an individual process medicines through your liver enzymes, and it looks at some clear known receptors, like how you might handle serotonin or adrenergic medications, whether you have homozygous or heterozygous alleles at some of the known genetic variances that affect these drugs. And it creates this pretty picture that does not tell you what drug you should take. And I think that's the most common misperception. Oh, I need that test so that I pick the right medicine. Well, it has nothing to do with that. What it does, though, is it kind of tells the doctor how to dose it, or if you might be more sensitive to side effects because of how you metabolize it. And it does create this beautiful 10+ page report where you get like fancy colors. If it's in the green, it means you dose it normally. If it's in the yellow, you might have to try a higher or lower dose. If it's in the red, it's like you're much more likely to have side effects. And it has it in 3 different ways. And it can really be helpful. And for people that have not responded to the taper up, they just haven't had any efficacy from expected doses, or people that have had horrible side effects at very low doses, and you have to have tried some and failed usually, this can be really, really helpful. And it's probably a whole separate lecture, but I've really had some cases where this has been life-changing and has really helped get the right dose. But it does not make you pick the right drug, but it is a tool, and it can be really helpful to understand that. And I think I have not personally used it for withdrawal symptoms, but I wonder how much that could or could not play a role. As I said, I have used it mostly for lack of efficacy with multiple failures or lots of side effects in the going up process. But I thought I would make sure I would mention that, because lots of people come in asking for it, not sure what it's for. Not all insurances pay for it. And this current test, I don't know what other ones are, but this current test costs like $330 out of pocket, if not. So these aren't cheap. And so certainly not something you want to do with everyone. But once you do it, it is really something that they can carry on their whole life. And although it's only running the pretty pages for the psychiatric medicines, the medicine receptors that they run through the liver do apply to other medicines. And sometimes every now and then you hear someone having a reaction to something else. You're like, oh, that medicine goes through that enzyme, and you don't process that very well. And it wasn't psychiatric medicine, but I wonder if that's why it has side effects. So it can be helpful. So the last part I have here is just some examples that I thought I would share. These are like real examples of real patients and things I did based on some of these guidelines. And as I said, some of them work beautifully, some of them don't, but I thought I'd give you some real cases of things that I tried to highlight some of these points. So the first one, this is a patient with really significant OCD that had been on Prozac 80 milligrams for years, had really not had a ton of side effects, but it just suddenly felt like it had stopped working. It was kind of that pooped out effect. We're having kind of more intrusive thoughts, and had never really tried anything else. So we're like, you were pretty ill before we started that Prozac. It was pretty dysfunctional. We don't want to like come off of it completely, but maybe it's time to do a cross taper. So with this example, you kind of think about like equivalent doses. And with OCD, we kind of know that you tend to need the higher doses of the SSRIs. And so what I did with this one was sort of think about Prozac 80 is going to Zoloft 200 or 20 to 30 milligrams of lexapro. And the cross taper I did with this patient, and I did this one every 2 weeks. And people tend to tolerate cross tapers better because it's a replacement of one medicine with the other. So you're not getting like the full withdrawal of the receptor. You're getting a little bit coverage of it, but I still talk about it. And I just went 20 milligrams down on the Prozac and 50 milligrams up on the Zoloft. And this patient tolerated it really quite well. and then seemed to have a pretty positive response to Zoloft. This is a patient where I tapered off of an SSRI. This was actually a patient that I had seen in childhood that went on and got older and wanted to get married and have a kid, and so had been on lexapro really for several years, had gotten through high school and college for panic attacks, and really had always had some degree of sexual side effects, but it was never enough to want to come off of it. But then they were thinking about having kids and to see if it got better. And they were like, you know, I did a lot of therapy. I really think I can come off of it. I haven't had a panic attack in a really long time. And so for this patient, we decided to try to come off of it, tried to really educate about with anxiety coming back and side effects, and really started this plan to go down the lexapro about 5 milligrams every month. Now, so I started off by saying, let's do 10 milligrams for a month and 5 milligrams. And if you have any problems, we'll try to stop it in 2 months. Well, she had a lot of side effects. She was probably one of the more sensitive ones. And so what we ended up doing is really having to sort of slow that down. So instead of going from 20 to 10, actually started going down to smaller doses. And so I ended up writing for like 5 milligram tablets, and she could kind of break the 5 milligrams in half and kind of go at 1.25 every couple of weeks as she was able to tolerate it. And she was able to kind of get off of it without those significant effects. And hers really were withdrawal. We didn't see a huge return of like panic attacks or anything. It's just pretty uncomfortable. So that was sort of an example of a much slower one than I initially set up. And she is really good. She kind of called me real fast. She just did not tolerate the drop at all. So we were able to I was like, go back up to what you were on. Then she went back to 20 and felt better. And then we kind of slowed it down from there. This is a patient this is actually one of the resident clinic examples. It was a new patient. This was a patient that had come on a very large dose of Ativan, 2 milligrams, 4 times a day, had been on for several years. This was related to a history of anxiety, but had injured his back and had gotten an opiate and had gone to pain clinic, and the pain clinic was like, you can't be on a benzo and an opiate. This isn't gonna work. No one's gonna write this for you. And so this patient was very compliant, wanted to follow the pain center's rules, and was like, maybe I need to come off of this, so I can get a pain treatment, but I don't know how. I've never been on anything else. And so there was a little bit more urgency. The painkiller was willing to work with us as long as it was monitored, but there's a little bit more urgency in terms of trying to get it off. So what we ended up doing is Ativan, lorazepam is very short acting. It's a medium acting one. It's not the shortest, but in order to make it a little bit more comfortable, we switched to clonazepam or Klonopin, which is a longer, more BID dosed medication. You converted roughly what the equivalent doses were. So the Klonopin 1 milligram is equal about 2 milligrams of lorazepam. So we're trying to manage about 4 milligrams equivalent of the clonazepam with the 8 milligrams of lorazepam, and tried about every 2 weeks to a month to kind of lower it. You see in the beginning went a little bit faster than that last sort of piece. The other things to consider again is we could have thought about adding some Neurontin or valproic or gabapentin to kind of help with those withdrawal symptoms. And we did it a little bit faster because of the opiates. Really, again, talking about withdrawal symptoms, this patient did not have complicated withdrawals and was pretty motivated, and ended up tolerating it really well. The other sort of thing to think about is this was a patient that had mostly had generalized anxiety and panic, but had actually never had the more traditional anxiety treatments before. And so this patient was particularly worried about panic attacks coming back. And so we actually thought about Cymbalta, which is an SNRI that actually can help with pain regulation a little bit on top of some of the generalized anxiety and panic. So this ended up being the treatment plan for this patient, and they did quite well with that. And the last one, this is the patient I actually just saw today in follow-up, and she's doing quite well. So this is a 16-year-old I had with bipolar 1 disorder. She had had recurrent episodes of mania and hospitalization, and had been psychotic, and ended up on 2 milligrams twice daily a risperidol, which actually had really helped, but she had had really substantial side effects that we had been trying to manage: weight gain, her weight had gone up, she had some bump in her cholesterol. And then she ended up developing amenorrhea, didn't have a period, and started having some breast discharge. I checked her prolactin, which was a lovely elevated 125. And we're like, oh, this is totally the Risperdal. We got to do something else. But she had been really, really sick and had been really hospitalized on lower doses, I think 3 times. And so it was really like, we need to taper you to something else. That one didn't block dopamine as much, but had a little bit better metabolic profile. And so we chose aripiprazole, targeting a 15 to 20 milligram range that was similar to the risperidol, to try to keep her psychotic symptoms and her manic symptoms under control. And then over the course of about 2 months, we used this taper, going up every 2 weeks by 5 milligrams of the aripiprazole and going down about 1 milligram on the risperidol. And she did quite well. And then we rechecked the prolactin. She actually didn't have any relapse in her symptoms psychiatrically when we did this. After about 2 months, 3 months, she started having periods again. Her lipids did improve slightly. It was a little harder to get the weight back, but the prolactin normalized and she no longer had breast tenderness, and she did quite well with this as well. So there are some random articles that I found this in. Most of them were very new. And as I said, there is lots of personal narratives about this topic if you want to go reading blogs as well. So I hope that was helpful. As I said, I was kind of fun to do this because I had never really looked at the data or the lack of data on some of these things, and made me feel a little bit better about what I was doing. But I think it's still really challenging. So does anybody have any questions?
Thank you, Dr. Swagger. We really appreciate it so much. And it was really interesting, like you said, and I appreciate you adding those examples at the end there as well. So we'll open it up for any questions from the group or maybe comments with your personal experiences. So feel free to unmute or chat in.
I think it was a great presentation. I really appreciate it. I do find Effexor and Paxil two that are really hard for people to come off of. It does take a very long time, especially for those two.
Yeah, and those are by far the worst. I'm glad you said that. I would agree. And the Paxil is the one that kind of auto-induces its receptor and is such a short half-life. It's really problematic. And I actually have taken to not really prescribing it anymore. It's so hard. Effexor also, I'm very cautious about that one. I give people lectures up front with Effexor, like, this one is really hard. If you miss this dose, you will feel it, because you are absolutely right. It is like, you even miss the timing of the dose. Some people will feel awful. So I'm glad you pointed those two out. Those are very well known to be more challenging than others.
Thank you so much, Chandra, for your question and comment. Anyone else with any questions?
Just one more thing regarding tapers and kind of across the board. One thing that may be helpful is getting into some of those lower doses. Just think about the dosage form, and maybe there's a liquid available to get to some of those lower doses if possible.
Yeah. It's an excellent point. And also along that line, even if it doesn't come into a liquid, I have had fabulous conversations with lots of pharmacists that compound it, that have put things into liquids I didn't know could be put into liquids. So if you know if there's a compounding pharmacy in your area, make friends with the pharmacist because they're amazing.
I can imagine. That's so interesting. Thank you. Thank you, Alicia, for your comment as well.
Yeah, thanks, guys. You know, I'm an open book. So antidepressants and weight gain, I've thought about quitting it completely. I've gained a significant amount of weight. Not that I was at my prime or anything when I started it, but it's like unhealthy. My cholesterol is higher, and it was already a little elevated. So I didn't know, like, is that a reason that people do taper off, or is there better ones? This might be more for, pharmacists.
Well, I'll have, so a lot, like I would say, so it's fascinating because when you look at the literature with the weight gain and the antidepressants, it is really all over the place a little bit. I mean, as a class, they're kind of weight neutral, but you absolutely have people that like clearly report that they've gained a lot of weight from it, and I mean, it makes sense because I mean, serotonin impacts satiety and our appetite centers, and we talk about sort of like carb craving for emotional control. I mean, there's a lot of like overlap. I've seen all of them cause weight loss, and I've seen them all probably cause weight gain. I think, again, there's this very individualized thing, and maybe our pharmacists can like tell us. I mean, I haven't seen like any clear way to sort of tease that out. I do think that if that is clearly related, I usually find that most people really want to try something else, or we switch classes and cross taper them to something. Lots of times, if the symptoms are in control, sometimes that's a reason to taper it off. I will say that the challenge with that, it's kind of the same thing with antipsychotics, is when you taper it off, it doesn't make the weight come off though. And so you want it to, but that's like a whole harder conversation. So even if the medicine wasn't inducing whatever it was that was causing appetite change, you really got to kind of support people in ways to also kind of take it off or find other things to do. With depression specifically, the one sometimes I add as bupropion, because bupropion, the Wellbutrin, actually is known to suppress appetite and help with that specifically. And sometimes, but that one's not good for anxiety. So, there's things that you can do, but if that's the reason, I always sort of try to pair it with other strategies to help them lose the weight or come up with some things, because even if you switch the medicine, you don't gain any more. People get frustrated, obviously, that they can't lose it. And that can also make you stressed out and overwhelmed. And
stress, cortisol, more fat, yay.
So I don't know, Alicia, do you have any more information about the weight? The weight stuff has always been so all over the place in the literature.
Yeah, and the antidepressants, not really, but like if you would use some of the antipsychotics, of course, those are associated. But as you mentioned, no clear correlation there.
So crazy. Thank you.
Thank you all so much. And thanks, Elizabeth, for your comment and question. Is there anything else from the group that anyone wanted to share? Maybe some personal experiences that they've had? It's a safe space, Elizabeth and I always like to say, so. All right, and Dr. Swagger, were there any other last items that you wanted to mention before I go into the announcements for today?
Nope.
Dr. Lillard, I noticed you unmuted there.
Yeah, I just, before you get into announcements, one of them is going to be that I'm presenting with our next session, and it is to be determined.
Yes.
I just wanted to see what others, if anybody had any thoughts or ideas, wanted something, I will definitely come up with something if you don't have an idea, but I'd love to present something that is meaningful to this group. And I know we're getting a bit of we've got a variety of providers and topics here, so.
Yeah, no, that's great, Dr. Lillard. Thank you. That's a great point. Anyone with suggestions, please feel free to chime in. You can always shoot us an email after the session if you prefer to send it anonymously or anything. So just let us know. Any thoughts?
If people don't have thoughts, my first thought is to go back to the chronic pain lecture from a few weeks ago and talk more about treatments for chronic pain with kids and adults. I thought that might be a good step.
That's great. I
so
know
if you really dislike that idea, then you should come up with your own.
I think that's a great idea for sure. I know chronic pain is a big topic. A lot of people have requested in the past as well. So if that's your plan B, that's a great plan B.
Sounds good.
Alrighty, but yeah, if I do hear from anyone at any point this coming week about topics, I'll definitely pass that along to you, Dr. Lillard. But big thank you, Dr. Swagger, for your presentation and helping with questions and all of that. We really appreciate it as always. The only announcement is that our next session will be on February 16th. Dr. Lillard will be presenting on whatever topic you guys send over. If no topics are sent over, we'll do the chronic pain topic again. So thank you all so much. We'll see you guys next time. Take care.